Okay, so thanks for inviting us to speak about the Living with Cancer dashboard today. And we'd like to talk about what we're doing to evidence driving change using quantitative and qualitative data. So I'm Kathie McPeake, and I'm Macmillan Living with Cancer Programme Manager for Lincolnshire, and I work for Lincolnshire Integrated Care Board. And Kelly?
Hi everyone, I'm Kelly Dixon. I'm the Senior Cancer Data Analyst for the Lincolnshire region. So I work across the Lincolnshire ICB and the Acute Trust as well.
Okay, lovely. So next slide, please, Kelly. Okay, so I think it would be useful to give a little bit of context around the Lincolnshire Living with Cancer programme and tell you a little bit about Lincolnshire as a whole. So as you can see from this map, we're situated on the eastern side of England. It's not quite as far east as you can get in England, but it's very close to it. We're the second largest county in England in terms of area, 2,697 square miles. We have a population of approximately 800,000 people, but this does change because we have a transient population of students, and also some of our communities out on the East Coast are transient in that they don't live there all the year around. We're characterised by rural and coastal communities, and unfortunately, many of our residents suffer from significant health inequalities around age and deprivation. So our age profile is higher than the England average for residents aged over 65. And there are areas of extreme deprivation on our East Coast. Some of our communities are in the top 10% of most deprived communities in England. And there are approximately 37,500 people living with cancer in our county, and this is predicted to rise to over 45,000 by 2030. Next slide, please, Kelly. So a bit of context as well around the development of our dashboard. So I'm sure many of you are aware that a cancer diagnosis can have an impact on a person way beyond their physical health. So it can impact their mental health, for instance, and their finances, their work, their relationships, and many other things. And evidence has shown that good holistic support given to people living with cancer before, during, and after their diagnosis can have a positive impact on their outcomes more than those people who don't have this kind of holistic support. So in 2016, the Lincolnshire Living with Cancer programme was established. It was initially funded by Macmillan Cancer Support, and they very kindly funded us for 7 years. Since 2016, you will be aware that in 2019, the NHS long-term plan was published, and this placed emphasis and a requirement for systems to implement personalised care and support for people living with cancer. And it's also placed a greater emphasis on tackling health inequalities. Following extensive patient and stakeholder engagement in 2016 and 27 to understand what the challenges were to living well after cancer diagnosis, the programme set its approach, its strategic priorities, objectives, and we published our first strategy. We refresh our strategy every 2 years to make sure that we're still going in the right direction, and we're now implementing our fourth strategy, which is set between 2023 and 2025, but also has a forward view to 2028. And this strategy is underpinned by further public and patient engagement and involvement, which was done in 2023. So the approach that we've taken synthesizes 5 evidence-based ways of working. So that's transformative, whole system, asset-based, place-based, and person-centered. And put simply, this means that we're creating a better and sustainable future for supporting people living with cancer, involving and integrating all relevant parts of the health and social care system, using the assets we already have, supporting people in the place that they would like and in the way that they would like, and placing people at the centre of everything that we do. Next slide, please, Kelly. Our 8 strategic priorities are transforming information flows and information governance, joining up fragmented pathways, integrating services, supporting workforces, improving communication and conversations, improving access to information, advice and support, enhancing and increasing support services, and tackling inequity across the county. Our strategy is being implemented across all pathways and all communities in Lincolnshire, and has a presence in acute services and the community, and we work with multiple system partners. The reason that we wanted to implement across all pathways and all communities in Lincolnshire is that it's unthinkable for us to say to patients, I'm sorry, you live in the right area, but you have the wrong sort of cancer, or you have the right sort of cancer, but you live in the wrong area. The programme has been evaluated using the theory of change, and the results of our evaluations are that we are evidencing positive change system-wide. In 2022, we secured recurrent funding from the Integrated Care Board for 8 of our roles, which was absolutely amazing. We no longer had to rely on external funding. However, at this point, we were told that we had to demonstrate our impact and a return on investment. And at this point, I had a little bit of a panic because I really didn't know where to begin. And I also thought that we didn't have any data. And I'm now going to hand over to Kelly.
Thank you, Kathie. So when I started with the team, that was in 2019, and the first tasks I was doing was always with acute data. So looking at performance, pathway analysis, pathway improvement. But when I sat down with Kathie and we started looking at the living with side of the programme, she was very clear that she had lots of work plans, lots of streams, lots of things going on, but she didn't have any data. They had patient stories, all sorts of really good things, but they couldn't find the data. So our biggest challenge was finding our evidence, finding our data. And this is where it is. We have all sorts of different organisations involved here. So at the centre, you have your national data, your Somerset Cancer Registry, your NCRAS, your Office for National Statistics. You also have data in Cancer Research UK, Macmillan Cancer Support, right down to our local coffee support groups. So there was data everywhere. But one of our biggest challenges was getting access to it and collating it into one area. So we started to do that. We started to sit and go through what could we get, what did we need, what did we have access to, and we started to put them all into a centralised location. But it's okay me having access to this data. It needed to be out there, used by people that needed it, not just me sitting on a data warehouse full of data that wasn't being used. So if I just bring up the dashboard. So this is a version of the dashboard. Now, one of the first things you will notice about this dashboard is it is built in Excel. And that has been very, very deliberate. So there are some fantastic programs out there. There's Power BI, Tableau, Athena, Federated Data Platform. There's so many different places that we could have published this data. We have chosen to go with Excel, mainly because we can completely bespoke all the data to what we need, what we want to show. We don't need technical skills to be able to write complicated coding. And we also had issues with sharing multi-organisations in Lincolnshire, because none of the organisations had any of the same software or the same licensing. And we wanted to be able to share this with the public. We wanted to share it with GPs, with charities, with our nurses, our clinicians. We wanted to put it widely available, and we didn't have any software which we could do that in the way that we wanted to. It has been built in Power Query, so Power Query sits behind it and collates all the information and the data, and then pulls it through into the Excel overlay. We do also load some of this data into Power BI as well for geographical mapping purposes. But as I say, the ICB doesn't actually have a Power BI license. And although ULHT has a Power BI license, they can't publish it. So we've stuck with Excel for a reason. So this is the main loading page when you go onto it. There's the public version and a specific ULHT version. So the difference between the two is these orange buttons over at the top right and these orange pages down at the bottom. Those are only available to ULHT staff because they do contain patient identifiable information. This is just a demo version, so I've actually taken that out of this demo. The public version is exactly the same information, apart from those orange sections don't exist. So this is the board report, and we sat through every part of Kathie's programme and said, well, what do you do? How do we measure it? What's the SMART KPI? So that the board can look at this and say, well, how's the programme doing? We have everything in here from the national requirement measures to programme implementation measures, right down to patient experience and the softer measures at the bottom, which are things that the ICB are involved in but don't necessarily run or maybe just monitor and just check that they're being utilised properly. So there's all sorts of different things in here. We do have SPCs as well from the majority of the metrics now. Some of them we don't quite have enough data points, but you just select the metric you want and your SPC chart will come up there. And as I say, we're developing this all the time. So more information, more data is constantly being loaded into there as people decide what they need. And we develop more data sources from various places. But what we said was our original plan was to make the data available out there. We wanted the CNSs to be able to look at their data and be able to drill down into things. I didn't have the time to be able to sit and go through every single data request. If we could get it self-service reporting, then we would do that. So that's where all these other buttons come in. So if we look at CNS contacts, this shows in our acute trust all the number of contacts that were had with cancer patients by our cancer nurse specialist team. All these buttons are filterable, so if I just wanted to look at breast, I can do that and the data on the screen will filter down. I can also say, actually, I just want to look at face-to-face contacts, and that will filter down as well. So our CNSs can have a look and say, well, actually, do we have enough workforce to do the number of contacts that we are dealing with on our tumour site? When they have those contacts, they also mark down in our system what kind of work they do during that contact. So do they give advice, or do they set up an appointment, or do they do some emotional and psychological support? So all that information is here and can be drilled down into. And we can see those trends over time and whether there's any ongoing referrals from those contacts. So we can see that benefits is quite high in all of ours. So we're looking at setting up benefit information for the patients to free up time for the CNSs to do more of that clinical activity work. As Kathie mentioned before, we have HNAs, and this is a holistic needs assessment, and we are required to do them by NHS England. So anybody that has a positive cancer diagnosis are required to have a HNA assessment. And this assessment records any concerns or distress that a patient may have as a result of their diagnosis or lifestyle. What they do, and I'll just flick onto distress because it shows it in a bit more detail. So this is what they record in the distress. So they record both a concern and a score. So we monitor how high they score it on a scale of 0 to 10, and how many people record that distress as well. So we do balance the two off. You can see here, alcohol or drugs is quite a high score, but we've actually only had very, very few people report that. I think that's 3 under there. Whereas sadness and depression is reported by over 1,000 patients, which obviously naturally brings the scoring down a bit more. We can just look at emotional concerns, and we can see that worry, fear, and anxiety is very, very high scoring on that. So what Kathie's team do is they take these results and set up programs where they're needed to be. So for the last year, they've been working on psychological and emotional support at all levels of the service. So that could be level 1 and 2 provided by the cancer nurse specialist, up to the more specialist support given by a qualified psychologist. We can see filter down even further. So for emotional concerns, we can see the distress scores. We can filter that down even further, see the distress over time, see the cancer sites that they're reporting. And in the associated Power BI board as well, we do have geographical mapping. So we can get that over Lincolnshire. There's other things as well in here, and as I say, there's lots more being built in all the time. We have another release going out by the end of this week, and that will contain transitional information. So those patients that are transitioning from a treatment pathway onto end of life or palliative pathway, and also looking at during treatment H&As in a bit more detail. The last part of it is that we look at is the case studies. So our community cancer coordinators are out in the community day in, day out, and they coordinate services for patients. But what we didn't know was what impact they had. So we looked at case study, and I'm going to use 2 as an example here. So it was a rank 2, which we say is actually a medium complexity. And this patient, as a result of the intervention they did, meant that they avoided 2 A&E attendances. If they'd attended those A&E attendances, it would be likely that this patient would have been admitted, and they would have had probably a minimum bed stay of 5 days for each occasion. Because we know the cost of those attendances, we can actually say, well, this case study had an acute avoidance of £3,148. We can then work that up over the year. We know what our complexity rates are. So 46% of our patients are highly complex, 21% have very, very little intervention at all. And we've actually calculated using this methodology that these 2 members of staff can save over £1 million in acute avoidance over the year. We're also looking at the social value aspect of this as well. So again, looking at case study 2, we know that without that intervention, this patient would not have gone for their surgery. And the clinical report for that was if they hadn't attended, they would not have survived the year. So what we're doing is we're looking at these additional values as well to see how we can measure the impact of that. That's going through our system at the moment with our personalisation partners, and the clinical and care directorate. So that is definitely one to watch in the future. And I think that's it for me, Kathie. I will hand back to you.
We could go on to the next slide. I think we've gone, that's it. Thank you very much. So I just wanted to give you some examples of before and after the dashboard. So before we had the dashboard, we used qualitative data only to identify health and well-being needs, and probably, to be honest, a bit of instinct. As a result of the dashboard, we can now use holistic needs assessment data to understand the most frequently cited concerns. We can break these down and we can understand the magnitude. And this is an example of this is our development of our level 4 psychology service to complement our existing psychological and emotional support offers at levels 1, 2 and 3. So there was a clear need for a clinical psychologist support for people experiencing extreme distress. And we have been able to, going from a 0.6 whole-time equivalent, we now have 3.2 whole-time equivalents of clinical psychology support in the county. And we have received funding from Macmillan Cancer Support and East Midlands Cancer Alliance. And some of the data from our dashboard will go towards evidencing or informing a business case to substantiate these roles. We can also identify communities and cohorts of patients with the most profound needs, which informs our service delivery. So where are we going to put in more of our support services in different parts of the county and with different communities? Another example is before the dashboard, the gaps in our workforce were identified on an ad hoc basis. And to be honest, sometimes if funding became available, there was a bit of a knee-jerk reaction to put in a post without actually thinking where the gaps were and where the needs were. So now we can evidence gaps in our workforce from HNA data and CNS and cancer care coordinator contacts data. So we know that in tumour sites where there's not a cancer care coordinator, HNA rates are lower than in other sites. And this is a clear inequality depending on what cancer you've got, depends on the support that you get. And also we can use this, as I said before, we can use this data to inform business cases to fill our gaps, evidence-based decision making. Finally, before the dashboard, our progress and impact was demonstrated by stories and case studies. Now we have KPIs for each sub-programme and project, and we can measure progress against our KPIs. And our qualitative data is analysed and a return on investment is applied to evidence our impact and the value of our team. Thank you, Kelly. Your turn again. Next slide.
Okay, so the future. So because it's been built in Excel, there's nothing massively technical about it. It's got Excel formulas. There's a little bit of VBA just to drive the icons, but it's nothing that can't be maintained in-house. So it's something that we can build, adapt, change in-house. We don't need to get that specialist knowledge of somebody who's an expert in Tableau or Athena. We can enrich that measurement. So looking at those case studies and that social value engine work, that will hugely impact how we monitor and measure the work that our system does across the system. We can develop our dashboard wider. It's only Excel. We can make it bigger. We can build multiples. We're looking at possibly bringing in other long-term conditions for Lincolnshire. So maybe looking at learning disability or dementia. There's so many other different ways that we can use the same dashboard, but for different data elements. And we're also in discussion with NHS England about sharing our dashboard out so that other regions can get the same kind of data and get the same kind of drill downs and find their gaps and find their issues. And Kathie is working with our peers at Lincoln University for peer publication as well.
Okay, so here's our cancer team, and this lovely photo is taken at our cancer summit, which took place on the 12th of June this year. We are seen to be a high-performing team. We've been lucky enough to win a number of awards, so Macmillan Professionals Excellence Awards. We've won a Sport and Physical Activity Award for our Fighting Fit programme, which is a level 4 cancer rehab programme. And recently, I was lucky enough to go down to the Royal College of Physicians in London to receive the Eric Watts Award for Excellence in Patient Engagement and Involvement. And we were shortlisted for an HSJ Digital Award this year. We didn't win, but we were so pleased to be shortlisted, especially when we saw who we were up against. We've spoken at a number of conferences. I spoke at the International Psycho-Oncology Symposium World Congress in Milan last year, and we were lucky enough to get an abstract accepted for IPOS 2024 in Maastricht in September. We're speaking at the Health and Care Analytics Conference tomorrow in Telford, and myself and another colleague spoke at a Development Economics Conference at the University of Lincoln last month, where we talked about the work that we're doing on financial inequalities for people living with cancer. So it's a privilege to lead this team from where we've gone in 2016 to where we are now. It's absolutely amazing to see all the hard work really coming to fruition. And the final slide, Kelly, please. So thank you very much for having us, and it's time for questions.